It's been a wonderful group of presentations thus far. I wonder now if we can dive a little bit into some discussion related to some of the different common themes that were discussed across the talks. I guess one of the things that I wanted to start with, maybe we could actually pick up some, Sabine, where you were just ending with, is really talking about the idea of actually using these types of data to actually alter the timing and delivery of interventions. And so I wonder, particularly, you know, there's a lot of promise and hope. I'm sure few would argue with that when you're presenting these types of data, but there's a lot of complications that can arise as we move from assessment and prediction to actual translation to adaptive treatments. I wonder if folks could discuss some of where they see some of the sticky issues, some of the things that will be challenging in incorporating and personalizing treatments based on some of these types of passively collected assessments. Any folks have thoughts on these issues and complications?
Well, I'll jump in just for the sake of jumping in. You know, I don't work really in the area of intervention. I did work with Tanzeem on the relapse project, and we did have this sort of slow timescale intervention with using BPRS, predicting BPRS. And here's my sense, and I don't want to offend anybody, but I see this. I love Tanzeem's pyramid. And, you know, I think one of the problems with just-in-time interventions or interventions driven by sensing data as opposed to something like a standalone CBT is that you have to have a lot of confidence when a signal is a psychological representation of, you know, depression or something like anxiety. So I see sort of like a gap between the pyramids to some degree. You know, the measurement, there's a lot of measurement techniques out there. There's a lot of sensors out there. There's lots of great theory on intervention. And so how do you bridge that gap? And what's in that gap for me are all the sort of classic problems of probably where we are technologically, which is, you know, we have incredibly noisy sensors. We have a huge amount of uncertainty built into the predictive models. We, as a community, because we have limited resources, we're sort of like challenged with reproducibility and replicability as well, to get confidence in sort of common results. Like one thing that's come out from a lot of the work David and Nick and Tanzeem is, you know, there are some indications that, for example, like location signal could be very important, but we haven't had that as a generalized result at a larger scale to have more confidence into it. So I'll finish by just saying, I think just-in-time intervention and interventions driven by sensors are a bit of a pipe dream right now, just to be controversial. You know.
I can follow up on that. I think so. I would push back on Andrew because we're friends. That saying pipe dreams is risky, right? It allows us to actually push away that problem. But I completely agree with you that it's risky. But how do we kind of navigate the middle ground, right? Like, so some of the sensor data is noisy and you can't do like really kind of robust clinical treatment, but what can you do, right? So for example, if you think disruption of sleep is associated with declining of mental health, you can deliver some intervention that can help with sleep, right? And then you can measure whether it's helping or not. And then you can also, I think one of the things which I've been kind of thinking and talked to David about as well, and is that in the clinical care, we often talk about stepped care model, right? Like you want to match the care of the person based on their severity to the treatment you receive. I think we have no parallel when it comes to personalized intervention or measurement, right? Like what we should have stepped measurement, we should have stepped intervention. So I think although we are not there yet to go up to the highest level, I think we can map out what the steps are, because I don't think we can jump to the highest level of intervention, but maybe we can take steps towards that compensate some of the limitations.
Yeah, I agree with that, and I actually agree with both of you, and Andrew and Tanzeem. I think we have to be really careful because it's risky business with the sensors right now, and there's a lot we don't understand. And at the same time, there are some small things that we are beginning to understand, and I feel like we can start studying them cautiously. I mean, David talked so much about the GPS, and I feel like we're getting a little bit of a better handle on that, and that also, you know, again, I work with a population that is associated with a high suicide risk, so you don't want to really mess around too much with it and getting it wrong here. But there are certain things, your sleep might also be okay, where you could do, in the context of a much larger CBT-ish intervention, where you could add a few things here and there, but obviously you don't want to go all the way out. Love to hear from David too.
Yeah, so I always appreciate, you know, Andrew coming up with the you know, something that's going to a controversial statement. So I think we all agree that the accuracy of what we can do is limited. I think we're talking about two separate things here. So one is, you know, can we use these kind of sense behaviors or sense data in the context of digital interventions, and the other is for detection in healthcare centers. And I think those are kind of two separate but related questions. So within, you know, interventions, I mean, you know, as you mentioned, Sabine, you know, sleep is a problem, and so if you identify, you know, if you can, you know, sense when people go to bed and get up, you can begin to use that data. You know, GPS data, you can, you know, I think we can kind of think about how that might fit into a behavioral activation paradigm. The problem is that you know, it's not exact. So how do you deal with uncertainty with the patient in those contexts? And so that's, you know, rather than saying, you know, we can't do this, I think it's also a question of how you manage the uncertainty, and certainly when you have intelligent systems that you're giving to patients, you know, there's if it gets it wrong, you know, the user is immediately going to question the intelligence of the system, and it's going to kind of damage the relationship. So it's really kind of a relationship between the user and the technology that has to be managed, and perhaps that's a tractable problem. You know, the other is in the context of healthcare systems. And again, you know, we're never going to be able to identify people with mental health problems with 100% accuracy. It's always going to be less than that. And so I think, again, the question is, with uncertain data or data with a certain amount of error in it, how are there ways that a healthcare system can use that information in a way that's beneficial? And you know, that then gets into processes in a healthcare system that you know, and sort of how it's implemented and where it's used, that it you know, it could be useful, but you know, you also don't want to activate a bunch of people in a healthcare system to go after people that are doing fine, because that's going to waste resources. So I think, again, it's, you know, a lot of this is about how we manage the uncertainty or the error.
Absolutely. Thanks everybody for your thoughts there. I think, like, I guess one thing I'd add is if we incorporated what would be traditional interventions that are already incorporated in as part of psychosocial interventions, and we just deliver them at what we think is a better time, most of them will be benign. Like, certainly there are probably critical decision making that we wouldn't want to hinge things on, like hospitalization or something along those lines. We wouldn't want to make a decision probably based on sensor data alone, but most of our interventions are probably decently benign to give to someone. And I guess I've been thinking a lot about not giving folks feedback that we detect that they're at risk at the moment, but actually just delivering the intervention. And they, if it isn't the right time, okay, maybe this goes into like a long-term skill set that they work towards, rather than like something that would be imminent and critical. But yeah, I think wonderful discussion. Andrew, thanks for the stir in the pot here. I loved that. I think it brings out some good discussion. I guess I'll be literally, I think every talk that I've given in the past 4 years or something like this, I've been asked a question about privacy. And I will anticipate that there are folks in the audience that have concerns about the type of data and how that raises concerns about privacy. How do you all conceptualize issues related to privacy in this space? And I guess just to hint in one direction of my own leaning, do you conceptualize any differences in how privacy is managed and handled within different types of positions? So in academia, research studies versus industry, and how that's all managed. So anyone want to discuss privacy?
I think that's a great question, and I'm glad that whoever raised it in the audience that they asked. You know, that is still a problem in this digital health space, because there's so many apps out there, and the way they deal with privacy really varies quite a bit. And I think a lot of people, a lot of users are not aware that if they download a free app, it's actually not really free at all. In some ways, they're paying with their data, and that's how often these app developers are monetizing or paying for their tool, right? So I think it's, and a lot of apps don't have any privacy policies at all, or they are very difficult to find. So I think as we are all here and we are sort of promoting digital health in some way, I think there's reason to be a little bit cautious. And if you are developing an app, you should really think about that right from the beginning. What kind of data is being collected? Who are you sharing these data with? So these are considerations that need to be made, I think, right from the beginning. And for the people who are more clinical in the audience, if you are thinking about using an app for your patients or recommending it for your patient, this is also something that you need to pay attention to. There are some websites that you can use where you can learn a little bit more about such things. Both David and I are actually pretty heavily involved in Cyber Guide, that's spelled PSY. BER and then Guide, Cyber Guide, where you can learn a little bit about privacy considerations that you should make while using the app. And then, well, maybe I'll stop right here. I could talk about this forever, but it's a really important question.
Yeah, I think again, I think there's kind of a couple questions embedded in there. I mean, one is, you know, as you're alluding to, Sabine, the commercial side, and you know, you're probably aware of the paper a few years ago that John Toros and Kit Huckbale in Australia put out, that, you know, it is not good what is happening out there. That a lot of companies don't have privacy policies. When they do, often when they say they're not selling the data, they in fact are. Yeah. So it's you know, the commercial world is difficult. The other side I think about is kind of, what do people want and what are they comfortable with? And what we've seen, we had a paper published a few years ago. When Jennifer Nicholas was the first author, you know, we asked people kind of how they would feel about different kinds of stakeholders getting those data or getting the sense behaviors, you know, whether it was their physicians or family members or EHR, which curiously people saw the EHR as very different than their physician, even though that would probably be the same thing. But you know, my sense is that you know, the sharing of the data really depends on, you know, where the value was. And so it made sense, for example, for sleep features to be shared with their physician. You know, people that, you know, were okay with that. They weren't comfortable sharing information about their communications with their physician. You know, it was mixed with respect to sharing with family members. So, you know, the question of privacy from a user's perspective is really kind of also dependent on who those data are being shared with and for what purposes.
Mm. Also, I think how it's kind of shared, like at what level of abstraction, right? Like you could share location data, but you could say significant location or kind of like circadian pattern that you're talking about, David, right? So these are different levels of abstraction, and I think we to this date haven't done a really good job of communicating that in a way that is easily understandable and accessible, right? Like David, you wrote a paper about just like whether we should use the term personal sensing versus phenotyping, right? I think that exists across the board in terms of how do you communicate exactly. Like location immediately has a connotation in everyone's mind. And when we talk about different location-derived attributes, it's very different, right?
Yeah, thank you for, that's my little soapbox thing, that even the language we use, like digital phenotyping, obscures the language for users. Nobody, so using language, we as in medicine came up with that term, but you computer scientists use things like personal sensing, which is much more understandable by the user. There's also, I think, kind of a question of control over the data that I know Deb Estrin and Katie Shilton have talked about for years, where, essentially, being able to give control over the data to people, and that's prospectively, who do they want their data to be used for, as well as retrospectively being able to remove data subsequently. So, if you're having your location sensed and you go off and do something that you don't want people to know about, that you have some control over those data, that you can remove data. So I think, finding ways of giving people control, both prospectively and retrospectively, to their data will, may be another avenue of managing these kinds of problems.
Maybe I'll just chip in a thought, which is just to add to the points that have been made by sort of colleagues here, that, I'm not bashing industry or I'm not supporting academia, but academia is a little different from industry, right? Academia, as researchers in academia, we're sort of driven by inquiry, and there are protocols within the organizations we work. Industry is primarily driven by profit. And, I fortunately worked for Google and Verily for over a year. And so definitely had great practices in those companies to do with privacy and security. But there's this issue, which is technology is changing so quickly, right? I mean, that adds to the noise and uncertainty. And the sort of systems that we work within, usually technology gets developed at a rate, and privacy always tries to catch up, right? And inevitably, what happens, what we're seeing in the press, is that tech companies, are sort of threatened with regulation. Of course, in the medical devices field, we have the FDA and that whole procedure. But my sense is that privacy, as more and more sensors get integrated into our daily lives, both wearables and in the places that we navigate through, I think our privacy is much more at risk as we move forward decade by decade. And I don't know collectively how people can push back against that. One thing we've heard about is owning your own data, but how do we really own our own data, right?
I guess there, kind of quickly to comment, like some of the pushback and the news articles that we've seen and other things have resulted in some change, right? In iOS, you can't just develop an app pulling all the data, and it will remind you if you have background sensing, right? So some of this is, and I think that's where, like, although like industry is kind of not incentivized, I don't think academia has the scale and the resources to actually execute. Like some of even the little things that Apple has done goes a long way towards privacy than we could have ever done. So I think we have to keep that public pressure that results in the industry that has the resources to actually implement some of those, because I don't think we would be able to do that. That's
fantastic discussion. Thank you all. We have just I think about a minute and a half left or something like that. My final question, and maybe I don't know if we'll really have a chance to answer this with any degree. Do you think right now we're at like the golden age of passive sensing? Because this, Tanzeem, this has been like very related to what you just said, right? Are we actually in the least regulated portion of most of the data that we can collect right now? We're trying to buck the systems that are constantly trying to decrease the amount of data and control we have access into the systems. the counter argument to this, of course, is that the amount of data that we have access to is growing constantly. The availability to pool this data is changing in a way that is unprecedented in probably other ways of passively collected data. So maybe not specific to smartphones, but thoughts on that one?
I hope so, but I fear not. You know, and I suspect that, yeah, no, I mean, I think, you know, even though it goes against my research program, I kind of hope that it gets more difficult, but I'm afraid that in this country, there's not a lot of appetite for control over these things.
I agree, and sometimes I think we don't need the level of data resolution that we are collecting to actually get something meaningful. So I think there is a trade-off that we don't consider as seriously unless like our hands are tied.
I think it's a golden era if companies or researchers like us and our colleagues can get into companies and can drive things forward. Then it could be the golden era of, as Tanzeem was saying, like connecting the sort of breakthroughs out at the sensor level, what we talked about, and prediction, with sort of in the clinic. If we can find a way to do that, then it's definitely a golden era.
Thank you all for this your wonderful presentations and discussions. I thoroughly enjoyed it, and hopefully everyone else did, I'm sure. And I appreciate you all giving your time. I think we're out of time, and I think Rachel may take over from here.